All right, Dr. Rosenfeld, I'm going to start broadcasting this meeting now, okay?
Go for it. Yep, go for it.
All right. Shoot.
It says live.
It does. Okay, there's the broadcast button. Okay. Hello, everyone. Welcome. We're going to be starting in just a couple minutes. All right, it looks like we've got a lot of people hopping on right now. Okay, we're going to go ahead and get started. Good evening, everyone, and thank you for joining us tonight. My name is Jennifer Claxton, and I'm the Director of Care Services for the ALS Association Golden West Chapter. We're very proud to host this special program for you tonight, the Coronavirus, COVID-19, and the ALS Community. Our special guest this evening is a member of the California ALS Research Network and the director of the Center for Restorative Neurology at Loma Linda Neurology, an ALS Association Certified Center of Excellence. We tried to show the camera in his beautiful suit and office that he was in, but it wasn't cooperating with us. So I wanted to share that Dr. Rosenfeld is all dressed up, but we can't see him. So please, everybody, welcome Dr. Jeffrey Rosenfeld.
Thank you very much, Jennifer. I hope you can hear me well.
Yes, yes.
Well, I also would like to welcome everyone and thank you so much for logging in. This is really quite a group. I think there have been over 200 or approximately 200 folks signed up, and I'm looking at the numbers are still increasing as we're going. So by all accounts, this is really an incredible time for all of us. And the purpose of tonight in broad strokes is to provide you some information and hopefully some reassurance, or at the very least, an opportunity to ask about the things that you're unsure about or that are most unsettling to you. I'll tell you that for me personally, it's actually very heartwarming to have been given this opportunity to do this, because our practice has really changed quite a bit in the last 2 weeks, and I feel very disconnected from so many of the patients that we would ordinarily be interacting with on a regular basis. And so I saw the list today, and I see so many of them are logging in. So hello to all of you. I know I can't see you, but you can hear me, and knowing that I'm at least reaching out and giving you a chance to ask questions and get some more information is comforting to me. Also, along with me tonight, I know that there are several of our team members that are joining in, and so if well, questions that they might be able to chime in on as well. So just a few housekeeping issues before we get started. I definitely want to spend the majority of the time tonight responding to your concerns and questions. I do have a presentation. I'm going to try not to talk for more than 25-30 minutes at most, and then use the rest of the time to answer your questions. I have already received about 25-30 questions, and during the course of the presentation tonight, you'll have the opportunity to ask questions as well. The best way to ask the questions would be to type them in to the Q&A link that should be at the top or bottom of your screen. If it's not appearing, if you bring the cursor to the top or bottom of your screen, a menu from Zoom should pop up, and Q&A is one of the options. If you click that one, then they will come to the panelists, and I'll try to address them at the end. There is a chat function as well. I'm going to be looking at those, but we'd like the questions to come through the Q&A. Jennifer, was there any other housekeeping issues other than the Q&A and logging in?
No, that's it. I just want to make sure that everybody understands the topic of the meeting tonight is directed at coronavirus, COVID-19, and the ALS community. So I want to just get that clear with everybody, because we always have so many questions related to ALS, but this is a huge topic, and I think it's going to take up our full hour. Go ahead, Dr. Rosenfeld.
Okay, so we're going to, let me just get my cursor back here. So we're going to start off tonight with a very brief video. I'm showing you this video, actually, Jennifer from ELSA, who just was speaking, sent this to me. And this is a video that was created by the World Health Organization. And I have to find it. Here we go. I'm going to share that with you. And hopefully the video will play. And I'm showing you this video because it's a very good starting point, a little bit of an overview, but it's also interesting because there are several facts that the World Health Organization published in this video as recently as 2 weeks ago that are no longer true. And so it's a reflection of just how fast our knowledge base is changing. So take a look at this and then we'll comment a little bit about what we know to be different than what's presented here.
In December 2019, there was a cluster of pneumonia cases in China. Investigations found that it was caused by a previously unknown virus, now named the 2019 novel coronavirus. In this video, we'll take a quick look at what's currently known about the virus. Keep in mind that this is a new virus, and what's known about the virus now might change in the future. Coronaviruses are a large group of viruses. They consist of a core of genetic material surrounded by an envelope with protein spikes. This gives it the appearance of a crown. Crown in Latin is called corona, and that's how these viruses get their name. There are different types of coronaviruses that cause respiratory and sometimes gastrointestinal symptoms. Respiratory disease can range from the common cold to pneumonia, and in most people, the symptoms tend to be mild. However, there are some types of coronaviruses that can cause severe disease. These include the severe acute respiratory syndrome coronavirus, first identified in China in 2003, and the Middle East respiratory syndrome coronavirus that was first identified in Saudi Arabia in 2012. The 2019 novel coronavirus was first identified in China. It initially occurred in a group of people with pneumonia who'd been associated with a seafood and live animal market in the city of Wuhan. The disease has since spread from those who were sick to others, including family members and healthcare staff. There are many cases at present, and the disease has spread within China and also to a number of other countries. So, where did the virus come from? It's known that coronaviruses circulate in a range of animals. Sometimes these viruses can make the jump from animals to humans. This is called a spillover and could be due to a range of factors, such as mutations in the virus or increased contact between humans and animals. For example, MERS-CoV is known to be transmitted from camels and SARS-CoV from civet cats. The animal reservoir of the 2019 novel coronavirus is not known yet. How is it transmitted? The exact dynamics of how the virus is transmitted is yet to be determined. In general, respiratory viruses are usually transmitted through droplets created when an infected person coughs or sneezes, or through something that has been contaminated with the virus. People most at risk of infection from the novel coronavirus are those in close contact with animals, such as live animal market workers, and those who are caring for people infected with the virus, such as family members or healthcare workers. So, how does the disease present? Well, from what is known so far, there can be a number of symptoms ranging from mild to severe. There can be fever and respiratory symptoms such as cough and shortness of breath. In more severe cases, there's been pneumonia, kidney failure, and death. The mortality rate is not known yet. How can we tell whether someone is infected? The infection can be diagnosed by a test called PCR, or polymerase chain reaction. This test identifies the virus based on its genetic fingerprint. There's currently no specific medication for the virus, and treatment is supportive care. There's currently no vaccine to protect against the virus. Treatment and vaccines are in development. How do we prevent transmission of the virus? This new virus currently has a limited geographic spread. However, there are a number of standard hygiene practices that have been recommended to protect against infection and further spread. These include covering your mouth and nose when coughing or sneezing with a medical mask, tissue, or flexed elbow, avoiding close contact with those who are unwell, the appropriate use of masks and personal protective equipment, especially in a healthcare setting, washing hands regularly with soap and water or alcohol-based hand rub. Actions that can be taken to prevent infection from an animal source include avoiding unnecessary unprotected contact with animals, washing hands after contact with animals or animal products, and ensuring that animal products are cooked thoroughly before they're consumed. It's important to stay home if you're feeling unwell, but if you have a fever, cough, and difficulty breathing, seek medical care early and share your previous travel history with your healthcare provider. That's a quick look at this emerging infectious disease. Given that this outbreak is evolving rapidly, what's known about this virus can change. Please check the websites below for the most up-to-date information.
All right, let me just exit this a little bit here. I'm going to exit that one off. And excuse me for 1 second. I think I've lost the screen there. Sorry, Jennifer. There we go. Are we back to sharing in the right one?
Yes, you are, Dr. Rosenfeld.
Okay, it's not in the presentation. I'll be with you in just a moment. I'm sorry, I got a. Is it in the presentation mode or not?
Not yet.
It's not actually working there. Just give me 1 moment. Sorry. I want to go through some of the issues that that they brought up in the video in just a moment and systematically. Well, there we go. Okay. Can't tell you exactly why that worked, but it did. Okay, sorry for that delay. So what I want to do tonight is talk about 3 different areas, 3 or 4 different areas of concern. Firstly, the basically, what is the virus? What is this virus? And as the video said, where did it come from? But more importantly, how did things spin so fast to where we got? Everybody's life has changed, and the degree to which this occurred and the speed at which this occurred, I think is worth commenting on. And then specifically talk about the clinical challenges that we've had in controlling this, and of course, the risk factors that the video alluded to as well. And then, as I mentioned, most of the time for questions. So we'll start out with, this is a picture, a model picture of what the virus looks like. This is called an RNA virus. And if there's time and questions relevant, I'll certainly talk about what's the difference between a virus and a bacteria and how viruses work. But coronaviruses as a class, they're not new. They're not novel. We've known about coronaviruses for a long time, and there are currently 6, before this one, there were 6 known coronaviruses. 4 of them were very common, and they are often associated with the common cold. 2 of them that made the news when they came on the scene, MERS and SARS, they had potentially fatal consequences, and they were very highly contagious. Actually, SARS was probably more contagious than COVID-19. And now to this list, they'll be adding COVID-19, which would make the 7th known coronavirus. Now, these viruses are called zoonotic, which means that we get them, they start out in a host of an animal. And from an animal, it reaches humans, another animal. Not all viruses do that, but these do. Now, unlike what the video showed, we have an idea of where this one came from. It came from either bats or pangolins. Now, I'll show you a picture of a pangolin because I honestly hadn't heard of that animal before this. But the reason why we suspect where this virus came from in those two animals is because the virus itself has been sequenced. We know the genetic code of this virus. And there's a lot of overlap between the genetic code of the virus and pieces of DNA that are unique to bats and other pieces of DNA that are unique to pangolins. So what they're not sure is if did the bat give it to the pangolin or the pangolin give it to the bat. Both of these bats and pangolins are actually sold in China for meat. Pangolins are used in Oriental medicine. This is a picture on the left of the screen of a pangolin. It's, I don't know if you call it cute, but it's kind of a cross between an anteater and an armadillo, I think. It's used a lot in Chinese medicine, and I guess the meat. I never know anybody that ate a pangolin, but ironically, the thing that it's used in Chinese medicine for is anxiety. So it's actually causing more anxiety than it probably treated. But and on the right are bats. Both pangolins and bats were present in the market in China where the index cases seem to come from. Let me give you a brief timeline, of how this came about. This all started in December of 2019 with descriptions of what was called a novel pneumonia in that cluster in that fish market in Wuhan, China. It's pretty incredible to think of how much has happened since December of 2019. But it was described in just a handful of people, and none of the usual suspects as to why they had bacteria, why they had pneumonia, bacteria, other viruses, and so on, came up. And so that started the investigation. So by January of 2020, the first patients were hospitalized. And they were noticing increasing numbers. In fact, the cases in Wuhan were doubling every week. By February, just 2 months ago, the first reports were in the medical literature. And the first reports, in addition to showing reports of that cluster from Wuhan to begin with, the initial cluster seemed to focus around 3 people, a 49-year-old woman who worked at the market, and so she was a suspect, a 61-year-old man who was a customer at the market, and a 32-year-old who was there all the time, but apparently didn't work there. The 49-year-old and the 32-year-old, they survived. They were hospitalized for a while. They survived and presumably now recovered. The 61-year-old gentleman died of this disease. So from the very onset, we knew that there was a variability about the fact that not everybody succumbs to the disease. Some of the cases were more mild. So the February 2020 was when we saw in the States here the first reports in the journals of what this disease looked like. They reported on the first 1,099 patients that were identified from the Wuhan district, and the incidence that was doubling by every week. By March, just 1 month later, we saw the first cases in the US, and that was in Washington State, in Kirkland area in Washington State, and there were 21 patients. So by the second week in March, we had our first reports of what was going on here in the States, and we were trying to learn from what was going on in China as to what to expect. So when I actually, for the purpose of this webinar, I went back and looked at those first reports from February of 2020, and it was a little disheartening. In fact, there were 2 things that'll be takeaway messages tonight that are quite disheartening. This is a slide that's kind of hard to read, I think, because it has so much going on it, but I want to focus on 3 things, 4 things. These are symptoms. This is a listing of the symptoms that the patients from China presented with when they went to the hospital. And interestingly, fever, cough, shortness of breath, if you look at the first column, those are all the patients. Fever on admission, these were people that came to the hospital, only 44% of them had a fever. In the cough area, only 67% had a cough. That means 60% of the patients that got admitted to the hospital didn't even have a fever. And 30% of the patients that admitted to the hospital didn't have a cough. Fatigue was very common, and shortness of breath was only 19%. So that's very humbling, because today when we're screening people, including my own building, to walk into my office every day, you have to pass by an army of nurses who ask the same questions. Do you have shortness of breath? Have you had a fever? Do you have a cough? Every day they ask the question. But at best, they might only get 40 to 60% of the patients on those screening questions. None of these symptoms really came up very high. That I thought was very humbling. That's a humbling reality. So what we take away from the China experience, and what we've learned since from endemic areas here in the States, is that yes, fever, cough, and shortness of breath are very telling and could be significant for coronavirus infection, but they're not very specific, and they're certainly not all that sensitive. We know from looking at these retrospective reports that 80% of the time, this is a fairly mild to moderate infection that does not require hospitalization. 15% are severe and 5% are critical, often leading to death. That's a huge variability. What we don't know is why. Why do some patients do so much better than others? And there's a lot of work on this right now, is to try to figure this out. This is a novel virus, meaning your body has likely never seen this before. However, some patients seem to have a different susceptibility to the severity of the infection. We know that the variability from the time of exposure to the onset of symptoms is also very variable, anywhere from 2 to 14 days. That's a mystery. Why is it so variable with respect to it could be having to do with the viral load, but we really don't know that. And we also know that the duration of the disease is really variable, 1 to 6 weeks, again, reflecting that different people have different severities. You're most susceptible or most contagious in the early days of the disease. And the last point on this slide is the second humbling reality that we're dealing with, and that is that you can be contagious before you have symptoms. That's very unsettling. It's one of the significant reasons why this has been such a challenge to manage, because we don't have a constellation of symptoms that indicate you have it. We can't always predict who to test. And even when patients are coming into the hospital, they have a pretty significant variability. Now, there are many different websites and dashboards that go together that you can follow if you like to do this kind of thing. If you're a dashboard kind of person and you like to see this, this is a snapshot of a dashboard that keeps track of the cases by areas. This happens to be one from Johns Hopkins. And I did this slide last night. So last night at about 8:30 at night, that point, there was 859,796 total confirmed cases. That doesn't mean infected people, because remember, we're not testing most people. In this country, we're only testing the people that come into the hospital that are very, very ill and are indicating, and some outpatients. In the US, as of last night, we had 189,618. Now, I just, in anticipation of this and before I came on, I clicked on the website again. The 859,000 number is now almost 100,000 more from last night at 8:30 till now. And in the US, the 189,618 that you can see on the left of the slide is now about 212,000. If it was easier to switch back and forth to the screens, I would show you, but you get the point. The US is leading the way now with regard to confirmed cases, and the rate of increase is really staggering. The world map that you see just shows pockets, and it is also a little misleading, because some of the countries that don't seem to show very many cases could have more to do with their level of detection or the sophistication of the detection in those countries than it does actually have to do with whether there are people there that are or are not ill. It's an interesting website. If you actually go to it, there's quite a bit you can link on and get all different kinds of breakdowns. In fact, there's another one that's quite interesting. It's called Worldometers. It's a website that counts a lot of things besides coronavirus. But what I also think is so eye-opening, and the third kind of disheartening piece of news, is the rate of new cases. So as I said, the total number that those previous slides showed, that's not as significant because it might be reflecting on who actually is being tested, not actually who has the virus. These two slides show the total cases and how they've changed in the US. And if I don't know if you can see my cursor here, but if you look at about the 100,000, we were at about 100,000 on March 26th. Today is April 1st. This is over 200,000. So in 4 to 5 days, we have doubled. In Wuhan, China, they were doubling at about every week. So the rate of new detection, the rate of new cases being detected is faster here than we initially anticipated from the first studies. The daily new cases, now again, this is the 31st here, this slide over here is the 31st. So the daily new cases, if you go to this Worldometers website, it's over 25,000 today. So you can imagine if we're adding 25,000 new cases in this country every day, it doesn't take, it's not very hard to imagine how fast this can grow. This is really shocking. Now, I want to talk a little bit about transmission, because this is I'm going to show you some graphics that came from an article from the Washington Post that my daughter sent me. And I really like this because it shows simplistically, if everybody who had the disease gave it to everybody that they contacted with, it would look like this. The brown dots are affected people, the gray dots are healthy people. And as the sick people contacted other sick people, nothing would happen. And it would just go on, and eventually the disease would peak and then die out. In reality, though, it's not a one-to-one transmission, and people don't stay sick, they get better. And once you're better, one of the hopes for this is that you have less of a chance to get sick again. So if we replay that model, but in this instance, the sick people make the healthy people sick, and then as the dots turn to purple, they're actually recovering. So eventually, the virus would die out because everybody that got it would recover. Now, in reality, in our population, oops, wrong one, sorry. In reality, in our population, it's a little bit more complicated. And what I want you to look at in this one is look at this graph over here. As people get affected, it'll show you the curve of affected people. These are healthy people over here in the gray. These are the increasing frequency of affected individuals in the brown, and these are the people that recovered. So this is a model of what it was like in New York, for example, before we had the restrictions that we do now. Affected people, every time they touch an unaffected person, they get sick. Now, eventually, they're going to start to recover, but you see how fast the rate grew up, much like we're seeing now. And then as more and more people recover and have antibodies, and they're not infectious anymore, it dies down. The rate of increase, this is only a model, and Harry Stevens, I think, is a graphic artist that works for the Washington Post. And so what I thought it was such a great representation of how the problem has evolved so quickly is because it's a very contagious virus, and it isn't exactly clear when the recovery takes place. That's also variable. Now, in our country, not that one, in our country, what we've done is we've tried to sequester, to say, have the sick people stay on their side and have the healthy people circulate. What happened though, and I'll show you here, Watch again, compare this graph up top with the previous graph that was on the slide just a moment ago. So if we wall off the people on the left, they infect each other, that is households and neighbors and things. But as the doors open up and they start to circulate again, it just delayed the onset. Now, it wasn't quite as bad as not having this sequestering in place, but it was short-lived because as soon as we stopped sequestering, or as soon as there was exceptions to it, we started to increase. So it's better than what we were doing before without that. One more example to kind of bring this home. Oops, not that one. One more example. This is one which is a model of social distancing, which is to say that at least, I think it's 75% of the dots don't move, but 25% of them do move. Look at how it affected the curve at the top by comparison to the other two. Only 25% of the people are moving. The rest of them are trying to stay in place and keep their distance. So the chance of getting more infected people is much less. So consequently, the change over time, the curve flattens, so to speak. So the implication of these models is that social distancing and limiting the interaction between people is even more effective than sequestering in place. It's popular today, and our government supports the fact that you should do both. You should sequester in place and be 6 feet apart from each other to try to get synergy between the two models. But I show this just because I thought it really made it come home for me when I saw this. So what can we do? This is really the question. We are learning every day about this. I would tell you that this is probably 10 to 1, the number of emails that I get in a day about COVID-19 far trumps anything else that I've had in the box. It's so much new information. Social distancing works, quarantining works, and hand washing works. That's what we know. We know that we've got to stop the spread. We also know now, although I didn't put it on the slide, that there are people that get better and likely have antibodies, making it less likely that you're going to get sick again, at least not this time around. And I'll talk about that possibility of the virus mutating. We know, and I'm gonna focus comments a little bit to the patient population and specifically how it's relevant to ALS. And some of the questions I think will get at this, the ones that I've seen before. There's two ways that people are susceptible. You can be susceptible because you're more likely to get the disease. That is, you have something wrong with your immune system, or you're weakened in some way and your immune system can't fight it. The second way is you can be susceptible because you can't fight it. You're not more likely to get it, but if you do get it, it's harder to fight. And that has to do with a number of other things. You could be sick with many things other than motor neuron disease and still have a challenge fighting it. Patients with motor neuron disease, ALS, and other motor neuron diseases, they don't have a greater susceptibility in that their immune system is likely not compromised. We don't generally think of motor neuron disease as an immunocompromised state. However, they are vulnerable because if you were to get infected, if your lungs are already not working on par and you have trouble clearing the secretions, for example, or you're trouble fighting it because of a weakened state, it can be a worse disease. So I consider them to be definitely susceptible, but not because they're more likely to get it, it's just harder to fight it. Interestingly, the other source of susceptibility and concern, and I think there were some questions about this as well, is on the part of the caregivers. Because one of the unique aspects of having a disease where there's respiratory equipment involved is it's very easy to aerosolize the secretions. A BiPAP machine, for example, does this on a routine basis by design. The exhale port will aerosolize these secretions. And if those secretions have virus in them, then whereas you can be really careful as a caregiver, if the patient has the disease, it's more likely to get it as a caregiver if you're breathing in the aerosolized secretions from the patient. It's not just BiPAP machine, suction machines are aerosolizing. Many things, the types of respiratory equipment that are less problematic with regard to aerosolizing secretions are what we call closed systems. If you're on a ventilator, for example, and you're on a ventilator with a trach that has a cuff on it, so there's no breathing around the trach, then those secretions are not being aerosolized. If the infection were to occur, they would be in the secretions, but it's not necessarily aerosolized in the room. So there are a lot to be said about what's the appropriate protective equipment, and I can tell you what we do in the hospital here and what you might want to do at home. Yeah, I'm getting a little bit on in time. I think what I'm going to do here is I'm going to pause because I think some of the questions, some of the issues I haven't raised yet or haven't responded to yet are covered in the questions. So I'm going to pause here for a moment, and I'd like to take your questions and concerns. And just to remind you, there's the Q&A box at the top or bottom of your screen, and it looks like some people put some chats in also, but that's
those are my chats, Dr. Rosenfeld, encouraging them to ask questions on the Q&A. We actually have 13 questions here. Are you able to view them, or did you want me to read them?
Hold on a second. I will try that. Oh, I can view them. Yes.
Awesome.
And I have 27 in front of me. So
you do?
Yeah.
Oh, yeah.
Some you sent me and some I got.
Yes, yes, yes. The ones I sent you from our registration site. So.
Okay, I'm reading that. I'm looking for the questions. Some of this is, I got it. Okay. Question here, if you are a caregiver for someone with ALS and you need to go to the pharmacy or grocery store, are there steps that you should take to protect yourself while you're out or when you get home? It's a very good question. The short answer is we don't know, but I'll tell you what we do know. We do know that the least interaction that you have, the least chance you have of contracting the disease is the caregiver. So if you have somebody at home and you're very worried about it, then yes, there's definitely an advantage to wearing a regular surgical mask when you go out of the house. And before you do anything, when you get home, you wash your hands very thoroughly. The mask protects you. Washing your hands protects the patient. So the combination of just a simple surgical mask, I don't think you have to do more than that. I don't think it has to be the N95 mask. In fact, here in the hospital, as I mentioned, for non-ventilated patients, they're just using regular surgical masks as a current recommendation. Probably if we had enough N95 masks, everybody would be using that one, but it's thought to be sufficient right now with a regular surgical mask. So hopefully that addresses that question. This says, I wish I could see the questions. A VLI compromise without electrolysis on a, I'm not sure there's a question here. Hand wash. Gloves can spread the disease if you don't remove them on a regular basis. Yeah, that's a good point. Gloves can spread the disease and the virus can live on gloves. And so, of course, taking your gloves off and changing them is very advisable. Oh, that was from Andrea. Hello. Am I missing other questions here? I know I can only see some. Let me get some from my.
Hi, Dr. Rosenfeld, it's Jennifer. I have a question for you. Somebody asked, are cough assist and suction machines available if we need them and associated equipment? There are a lot of questions on here regarding ventilators and the availability of ventilators. Could you try to cover that topic for us?
Absolutely. So ventilators, as you know, are in short supply. But what isn't really understood is that a lot of you might be using BiPAP machines, particularly Trilogy machines and Vosen machines, and a couple on the market that actually are both non-invasive and invasive ventilators. So a while back, some years back, there was a big disparity between what we call non-invasive ventilation, which was BiPAP and CPAP, and what we call invasive ventilation, which is tracheostomy breathing. And there were different machines for different functions. But about, I don't know how many years ago, not that many, but some years ago, they started to introduce machines that could serve as both functions. Trilogy is the best example. And a Trilogy machine is both a BiPAP machine or it can be a ventilator. So when we're talking about, I've actually had this discussion with our respiratory therapist, when they're talking about a ventilator shortage, are they taking into account all the Trilogies that are out there, which are not generally used as workhorse ventilators in a hospital, but are we taking into account the availability of the non-invasive, so to speak, non-invasive Trilogy ventilators and making them invasive? So the answer is probably not. So if you have a machine in your house, especially if you have a Trilogy or a Vosen or some of the others, yes, that can be used as a ventilator. I haven't yet heard of shortages of suction machines or cough assist machines. So I would have to say we're probably good in that department. The challenge that's happening now is that the ventilators that are needed the most, of course, are needed in ICU settings in emergencies. So I suspect as time goes on, we will get smarter about, or more resourceful as to where we're finding these ventilators.
Dr. Rosenfeld, there's another question regarding a ventilator. It says, are vent-dependent patients more vulnerable or more protected due to being on a ventilator with bacterial filters?
Yeah, so I might have answered this earlier, but it's a little bit of both. In the balance, I think you're more protected because you're breathing filtered air and it's a closed system. Unless you have a trach without a cuff, then of course it's not so closed. But assuming that the trach has got a cuff around it and the air, and it's a closed system on the ventilator, there's no data about this, but you're breathing a subset of the air that the rest of us are. So I would say less. Where you have more vulnerability is if techniques like for invasive suctioning, if they're not done in a sterile fashion, you have more vulnerability to introduce bacteria. And as a result, you'd have to fight the infection. So the caregivers have to be extra vigilant about sterile technique, especially at these times. But without that risk, without that extra risk, I would say it's possibly slightly more protected.
Okay, we have a couple more regarding ventilators. I'm going to try to put them all together. I have one question regarding, oh gosh, where did they go? Sorry about that. The question was related to if there's a number of respirators, how will they decide who gets one? Will ALS patients be deprioritized due to their prognosis?
That is a hard question. And it's one that we don't like to think about because in our country, we haven't really been pushed to make those kind of judgments as to who gets the support and who doesn't. We're hoping we never have to answer that question. If you're asking me what would happen if, they're doing this in Italy right now. In Italy, I was listening to a doctor being interviewed who said, you know, you have a 80-year-old who has some lung disease, who's fighting, and you have a 23-year-old who has no lung disease and is fighting, who do we give the ventilator to? And he sort of implied without saying that they give it to the younger person who's got, you know, the life potential ahead of them. It's an awful situation. It's an ethical nightmare. There has been no policy that I'm aware of. There's certainly nothing that I'm aware of here in our hospital which would say there's a priority list, because right now we're not strapped in that way. We're seeing what's happening in New York right now. New York has made it very clear that they're short on ventilators. Fortunately, I think they have a new influx of ventilators, so maybe they also won't have to make that kind of awful decision. But if an ethicist were on the phone here, if an ethicist were talking, they would say that there is probably an ethical tenet that would say the chronically ill person might not have the same selective advantage at vying for limited resource as the healthier young person, but I really don't know. I mean, it's hard to even think about. I hope we never have to do that.
Yeah. One more question on ventilators here that I have. I know we're starting to make more respirators. Do we have enough respiratory therapists to operate all of them?
Yeah, another excellent question. And at the moment, that hasn't been a very relevant issue because the respirators are being used in the hospitals. These are not home ventilated patients. These are hospital ventilated patients. I know that the respiratory therapy staff in our hospital is really stretched, and even more so in higher areas where there's more patients. So yes, at the moment there are enough. I think if Andrea's on the call, and I'm sure she could chime in here also, but I don't think her microphone is working. I think that all respiratory therapists, if they wanted more work, they wouldn't have trouble right now. There's plenty going on. Yeah.
Okay. We're moving off the ventilator questions here. We have a question that says, should I request fewer caregivers assigned to me from an agency?
In general, that's a good strategy. You have to balance that against what the kind of care that they can provide. But if fewer people can provide the same care, it's one less variable.
Okay, great answer. What grade of gloves are needed, medical, cooking, or automotive?
Well, I don't actually know. You know, the purpose of the glove is just to give you something to throw away. Should it be contaminated? So you want a glove that's not going to be porous. Like you wouldn't use necessarily garden gloves because you know that's a softer material. So any kind of a latex glove that you could use to provide a barrier between you and the thing that you're touching. So automotive gloves, at least my experience with automotive, so to speak, automotive gloves. I don't know if you're talking about the driving gloves. They're generally not so good because they're leather and material. Cooking gloves, I don't know what that is actually, so I'm not going to comment on that one. And
those are rubber gloves.
Oh, rubber gloves. Rubber gloves would be fine, although you probably don't want to throw them out, you know, because you'd have to, you could, I suppose, dip them in bleach or something. But generally, the disposable kind of latex gloves, I would say would be the best bet.
All right, thank you. If the ALS patient is at a skilled nursing facility, are there any additional precautions that must be taken?
If they were at a skilled nursing facility?
Yeah. Yes.
Well, I guess it would depend on the timing. If they were at a skilled nursing facility in the last month, then of course we would, and assuming they're not there now, I guess by the tone of the question, then I would say we would watch that person very carefully. We would probably isolate them for at least 2 weeks. However, there's no formal recommendation for that. Now, if there was a reported case at that nursing home, then there is a recommendation for that. So I would say it's a little bit depends on the circumstance. Nursing homes are a very hot topic right now because they tend to be so endemic, including right in this region right now.
All right, so I have 2 questions regarding the pneumonia vaccination. And they're basically saying the same thing. If I've had the pneumonia vaccination, are you as likely to get pneumonia and die from this disease?
It's almost unrelated because none of the vaccines, the pneumonia vaccines that we gave out, would cover this. So it's a non sequitur, a moot point, because it's not relevant to this. It's not more or less likely, it's just not covered. We didn't know about this back then. We didn't know about this piece of DNA. A virus is different than some of the pneumonias that you get can either be from bacteria or from viruses. But this is a virus, and we didn't know about this one when the pneumonia vaccines were developed.
Okay, thank you for that. Some questions regarding masks. Two questions.
Yeah.
Should you wear a mask when out in public, and how well, if at all, do homemade cloth masks work?
Yeah, well, the answer to whether you should wear a mask in public, there's no recommendation currently that everybody should wear a mask in public. Um, it doesn't hurt. The question really is, does it help? And we don't have data for that. When you're out in public, it a little bit depends upon where you are. If you're taking a walk and nobody's around or nobody's very close to you, it probably doesn't do anything. Being outside in general with air that circulates and you're not in vulnerable distance of anybody's aerosolized secretions, it's probably the mask does nothing. Passing somebody from the other side of the street, not an issue. Talking to somebody in their yard when you're on the sidewalk, not an issue. So it a little bit depends. If you're going out, and by out you mean standing in line at Costco or Sam's Club, maybe, because as I pass that line every day, they're not 6 feet apart. And as you saw from the graphic illustration, that's a very effective suppressant. So it's not a sure thing, but I would say the answer to my question, to that question, would be dependent upon where you're going.
Great. Okay, I have two related questions here, Dr. Rosenfeld, regarding folks that live in the home with other people. One says, my primary caregiver, my husband, is considered essential staff at his work. Should he still be going to work? Can he be excused to stay home and still be paid? And the other one is regarding a daughter who works in the child care center, and they are wondering if it is wise for her to not return to work until it is safe.
Well,
and the daughter lives with them.
Right. They're good questions. And the first one is, whatever we can do to lessen the risk, to lessen the spread. So if you work in a place where you think there's a reasonable chance that the virus could be, as in a child care facility or a nursing facility, it's not absolute. It's not to say you absolutely shouldn't go to work. I mean, if you're an essential employee and you're careful and you use protective equipment and you're coming home and you're washing your hands thoroughly and you're wearing the mask when you're interacting with the patient, you're doing everything correct. So it's not to the point where we would say, there's an absolute reason not to do that. That said, everybody has a different level of tolerance for their risk. And some folks would just not want to accept even the remotest chance. I had a patient today that called me, and similar situation. He worked at a FedEx shipping plant and, deals with packages more than people, but was just so adverse to the fact that the virus could be on one of the packages or so, didn't want to go to work. The government so far has not given you a free pass just to say, I'm essential, but I don't care. But that's a decision that everybody has to make. Medically, it's a little bit of a gray area because you can take adequate protective equipment and take precautions to limit the probability. There's a question here that I got, Jennifer.
Sure.
It was interesting. My daughter is in a skilled nursing facility. What are the 3 most important questions I should ask? I think that's a great question, because what I would ask is, what screening do you have for your staff? But I wouldn't ask the administration that question. I wouldn't ask the administration or the person in charge, the supervisors on the floor. I would ask the person that is doing the janitorial work, or I would ask the person that might be, bringing the trays around or serving, and say, if you don't feel well, what recourse do you have, whether you could or couldn't come to work? How much flexibility do you have, whether you can come to work? I would ask the nurses and everybody, what screening are you asked any questions? Are you monitoring anything for symptom-wise? You want there to be some mindfulness on the part of the institution that they're sensitive to the issues that one or more of their employees could have the virus. Now, as you saw before, one of the humbling takeaway messages is we don't always know. The symptoms aren't telltale. The fever is not always telltale, and you could be shedding the virus even before you have symptoms. So you can't really be 100% sure. But I certainly, I mean, everybody in institutions is very nervous right now because it's such a sensitive area. So you want to ask the person that's affected by the policy, not ask the person that made the policy as to what recourse they have.
Thank you, Dr. Rosenfeld.
Another question I got here was, can my respirator serve as a ventilator? Yes, we talked about that. Some of them can. I'm assuming you mean your non-invasive BiPAP machine. Some of them can, and I would encourage you to call us. We can talk you through that if or no, and in a short time, Angie will be back, and she can take the calls directly as well, and we can address that. We answered the grocery store one here. This is a good one. What keeps me awake at night?
Good one.
Yeah, well, there's a few things. On this subject, I'm assuming they meant what keeps me awake about this subject. There's other things, but on this subject, I would say the fact that we don't have a firm handle on how to detect it, how to treat it, and how to control it. We're best at how to control it. We got that one further along because we know what's working in the right direction. We don't know how to detect it because we're not testing everybody. The best case scenario is you would get tested, everybody would get tested. You know, for example, just to use an analogy, if you work in a healthcare facility, you're tested for tuberculosis every year. There's a skin test. We do it every year. I have to go through it. Everybody goes through it every year because they don't care if you're affected with tuberculosis. They want to know if you've been exposed to tuberculosis. Best case scenario, if we could do that with coronavirus, we would test everybody and find out who shouldn't be working, who should be sequestered, who we should watch to let the virus run its course. That's very unsettling to me that we don't have a handle like that. I'm very worried about the absence of an organized effort in the country. It seems like most of the states are sort of acting on their own, and that's unsettling to me as well. So yeah, good question.
Dr. Rosenfeld, I have a couple questions pertaining to testing here. One of them says, should all ALS patients not just get tested right now? And the other is, could you be misdiagnosed with flu strand A?
Right. So the first answer to the first question is no. I do not think that all ALS patients should get tested right now for two reasons. If you were positive, I don't know that we would do anything else other than watch you and control your symptoms, which we should be doing anyway. Secondly, we don't really have tests available for all ALS patients, much like we don't have tests available for all healthcare providers. So the combination of limited resources and lack of benefit of the information would suggest to me that maybe not. I don't think it's going to be helpful.
Great. So we're coming up on the 7 o'clock hour, and I'm hoping you'll hang in there with us a little bit longer, Dr.
No, absolutely. Mm-hmm.
Great, great, great. So we have a lot more questions that haven't been answered, and I know you have some in front of you.
Yeah.
So I'm trying to look through here and to see that we're not missing something you haven't already covered. There is a really important one from someone who has a Mickey that was initially inserted in November, and it's scheduled for replacement this month. She's concerned about going into the hospital as an outpatient during this time, and she's wondering if there's an increased risk for that.
I'm sorry, what she's having replaced is what? I couldn't hear.
Mickey tube, a G-tube, essentially.
A G-tube, yeah. So yes, we are limiting. The reason why at Loma Linda and many other facilities, why they've shut down most outpatient care is for that reason. They're trying to limit person-to-person exposure. So if it can be done in an office, that'd be better. If it can be done in an expedient way so that the office, you call ahead and you say, look, I really want to limit my time in the office. I'm going to arrive at this time. Can I be taken right away? Can I leave right away? Changing out a Mickey tube is not a very time consuming activity. It's usually very quick. if there's already the same kind of, depends upon how easy the tube change is, it is possible to do it in a home setting, but most nursing organizations wouldn't allow their nurses to do it. So it's worth a call to the practitioner to say, is there a way that we could expedite this or put it off if necessary? Depends upon, I guess, how badly the change needs to occur.
Thank you. Did you have any you wanted to answer, Dr. Rosenfeld?
Let me take a look here. Yeah, I got so many here. Somebody asked me about a pulse. Does COVID-19 affect my current pulse? The pulse is a document that says what end-of-life care should involve. And it is not affected by, I assume the question would imply that if I got sick, if a person got sick with COVID-19, would their pulse that they had placed at the time of ALS, would it count? The answer is yes. It's not a protection or a document about the disease. It's a document about the wishes of the person. So the COVID-19 would not affect the current pulse that I'm aware of.
Great. I have one about, at what stage of the symptoms should we consider going to the hospital?
Yeah, that's easier. I would say, fortunately, most ALS patients are very vigilant about their symptoms. And you know, if you're short of breath, you know how short of breath you are. If something out of the ordinary were coming, fever, absolutely no question, hands down, I would, call us and probably we're going to get you in on a high fever, not a little fever, a high fever. And shortness of breath. Shortness of breath beyond your baseline would give me reason to suspect something else is going on. Now, while COVID is exploding and while we're kind of running around to try to put the fires out, people still do get routine flu and cold. So, we're coming to the tail end of flu season, but nonetheless, it doesn't necessarily mean any symptom means COVID-19, but it has to do with your symptoms, not with your level of suspicion. In other words, just worrying about it is not enough. If shortness of breath is what would move me to act more. I have a question actually for you. This is Rich. Yeah, they say, what services from ALSA are they providing during this pandemic?
Well, we have taken all of our services online. Unfortunately, we've had to suspend any home visits and suspend any in-person support group meetings. So if you go to our webpage, and you look at our calendar, you'll see all of the new virtual support groups that are being created, and you should all receive an email shortly if you are associated with our chapter that will show you all of our up and coming webinars or support group meetings. Goodness. And we're still here for you. Still reach out to your care manager. They can still help walk you through all of this. They can help you navigate your clinic visits, your virtual clinic visits with your healthcare providers, and they can help you navigate support that's available out in the community for you as well.
Good. There's a question that I have about what impact has this had on clinical trials and research? Yeah, that's a work in progress. I will tell you, I can speak for Loma Linda. I know that other institutions have been shut it down, basically. We haven't shut it down. It's slowed down a bit because we're not seeing very many in-person visits anymore. Most of them are video visits. It comes at a bad time because we're about to start 3 new clinical trials here at Loma Linda. My intention right now is, as we start to see patients again, is to continue to enroll in these trials and try to make the study visit as brief as possible. Several of our trials, not all in ALS, but several of our trials have allowed a change in protocol to allow the blood draw and some of the testing to be done in the home setting. So it has affected a change in the protocol. It's affected the rate to which we're recruiting into new trials. But it's not actually a deterrent with respect to say, well, we can't do those trials, so let's put it back on the shelf. It's just delayed things a little bit because of the patient flow.
Great. There was actually a second component to the what keeps you up at night, and I'm going to finish that question here. It says, are there other precautions ALS patients and caregivers should do beyond what the federal and state recommendations are? Anything in addition to the CDC precautions and recommendations?
Well, I think we kind of alluded to it in other questions. You can't be too cautious, right? So precaution, nobody is getting hurt by being too cautious. The question came up about, when to wear the mask or not to wear the mask. So if you wear the mask, if you're out of the house and then you're coming back into the house and you wear the mask, even though you don't think you had any exposures when you were out of the house, yes, that's a good idea, right? So you can always be, it has a little bit to do with your tolerance for risk and a little bit to do with common sense, but you can't be too cautious until this calms down, until this dies down. There's just too many pockets that come up. So some of what I said tonight about the gloving and about the specifics of a ventilator, closed system, open system, those have not made it to the CDC or the government regulations yet. Those are things that are kind of common sense. The vulnerable areas are suctioning. There's a definite vulnerability. Nebulizers are definitely vulnerable because a nebulizer is aerosolizing a medication. You're breathing that in and you're exhaling. So not only are you exhaling some of the medicine, you're exhaling aerosolized secretions brought about by the pressure of the nebulizer. So those are things that would make a caregiver perhaps vulnerable if a patient had it and was getting the nebulizer treatment. So wearing a mask is a good idea. And wearing gloves that you dispose of in between tasks is a good idea.
All right, we are down to our last few questions, and I know you have a couple more on your page. So I think you might have answered this one, but I want to make sure that the answer was sufficient for this person. They said, are ALS patients more likely to have difficulty fighting COVID when infected?
Say that again, please.
Are ALS patients more likely to have difficulty fighting COVID-19 when infected?
Yes, the answer is yes. One of the things in the pathophysiology of the disease is that there's a very significant inflammatory reaction in the lung. And that inflammatory reaction is associated with secretions and swelling of the lung tissues and making it harder to exchange oxygen. That's why there's so much shortness of breath. And that's why patients on the ventilators need a very high pressure to overcome that. If you're already weakened and you already have trouble clearing secretions and you already have trouble exchanging the oxygen because of air exchange, it will make it harder. So as I mentioned, you're not more vulnerable to getting it, but you are more vulnerable to fighting it.
Okay, I have one more question here. Can the virus come through the eyes?
Yes. The answer is yes. That's where "don't touch your face" came from, because if it's on your hands, you rub your eyes, you rub your nose. Yes, it can come through your eyes.
Okay. All right.
Just scanning down here. Don't see, I think we've addressed most of these as I'm looking.
Yeah.
Is there anything in the chat room I haven't been able to look?
Oh yes, I've been so busy looking at questions. There's a lot in the chat room here. I think we've addressed all of these that were hit in the chat room.
Right. There's a question here that came about going to an ALS appointment. When should I go? Should it be postponed? What I can speak to is what we're doing here at Loma Linda. We're trying to convert the entire multidisciplinary team to video visits. We've actually done it already. We're going to be rolling it out in a bigger way than we had before very shortly. And we're trying to preserve the one-on-one inpatient visits to the folks that really need to see myself or one of the team members that are there. That is different in different institutions. I know that in Northern California, I spoke to one of my colleagues and they see 0 patients, period. They're doing video visits only or not seeing anybody. I think there's a couple of institutions in our neighboring areas, and they too have curtailed down. I know this is a really unsettling time. I know there's a lot of information, and I think visits can serve multiple purposes as long as the risk is not so great at having it. I want to be there. We want to be there for the patients that need us. And as our staff becomes even more available in the next couple of weeks, I think we'll reach out to you, and hopefully you'll reach out to us. And we will see you if we need to.
Okay, Dr. Rosenfeld, I think we're going to have to come to the end of the meeting. I know that everybody still has a lot of questions, and I wish we had unlimited time for everybody. Just a reminder, if your question was not answered, please send us an email at careservices@alsagoldenwest.org. And someone will get back to you regarding your questions. Again, that's careservices@alsagoldenwest.org. And while you're at it, if you want to check out our website, we have a wonderful page on all things COVID-19. You can find that at our ALSA Golden West chapter or alsagwc.org. And you can click on the COVID page. So you can see if there's any more answers to your questions there. I want to thank you all for participating. If you would like to support this free educational programming, please consider making a donation today at give.alsagoldenwest.org. Please stay tuned to our website and our announcements. We are hoping to host many more sessions like this in the near future. So with that, I'm going to say goodbye and thank you all for joining us.
Thank you very much, Jennifer, for having this.
Thank you so much, Dr. Rosenfeld. We really appreciate you lending us your time and your expertise.
My pleasure. Thanks.
Bye-bye.